Let's start with question number 2. We've got an extensive destruction of penile herpetic vesicle lesions using cryosurgery. I looked under the main term destruction in the index 1021. And then from destruction, I went to penile and then extensive. And I got code 54065 on page 418. I think the main term there is the fact that it is extensive. Question number 4, and quite a few of you got this one wrong, and a lot of it is because of you need to read notes. Physician provides the technical and professional component of a cystography with contrast in 4 views. Patient has hematuria. I started looking up on the cysto. And if you look at page, you get 51600. Let's look at page 407 for the 51600. And it says that it is the injection procedure for the cysto. And in the notes, it says for the supervision interpretation, you need to look at those codes, the 74430. They did the technical and the professional, meaning they did the whole thing. They did the cysto as well as they did the views. So I have to pick up both of those codes. So if you go on page 526 to look at 74430, at 526, 74430, it says that it's a minimum of 3 views, and it is for the supervision and in the interpretation. So you need to pick up those 2 codes together. There's no modifiers, there's no 51s, there's no nothing. It's just straight up, those are the 2 codes. Those 2 codes together equal a global, because it says they did the technical and the professional. And in GU, there's quite a bit of codes like that where the doctors do the procedure along with like the shooting of the dye or imaging or guidance or those kinds of things, so that they do the whole thing. Number 5. On this one, I know one person got it wrong, and I can't remember if it was like a number transposition or what it was, but if you look up hypospadias, and then on page 1072 on the index, and we're going to pick up the 1 stage, some of that stuff might not mean a whole heck of a lot. It's just a bunch of words that you're looking at, but the 2 codes that you're going to be directed to is 54322 and 54336. So let's go to page 420. And we're going to look at, first we're going to start with 54322, which is a 1-stage hypospadias repair. And it does say it's with circumcision. And then if you look at the other one, which is 36, it does also talk about that it is a perineal repair versus the distal repair. So right there, just based on that, I would pick up the 322. but also the circumcision is not included in the 3-6. So the code is 54322. Question number 6. This one's similar to the other one where you pick up 2 codes for the biopsy with the guidance. You're going to look at biopsy and prostate. Most of you got the biopsy code, which is 55700. Look on page 424 because there's a note on 55700. And it says if imaging guidance is performed, and then it tells you, which codes to look at. The first one is 76942. And they did do ultrasonic guidance. So you're going to go ahead and check those codes out. And it does say page 541. .541 is 76942, and it's ultrasonic guidance for needle placement. So you're going to use both of those codes. You're going to use the 55700 and the 76942. There is no 51 modifier that goes with those. Those two together are the technical and the professional component. You have to do the two together. And you don't add 51 modifiers on those. Question number 7 is a dilation of a urethral or with a dilator for a stricture. If you look up dilation and then urethra, you're going to get 43600 on page 416. And that code is going to be dilation of urethral stricture with the urethra dilator, which is exactly what was done. Question number 9. Sue Lynn has a Pap test. The pathology report comes back positive for malignancy. Physician recommends and performs a colposcopy. Evidence of further primary malignancy of the uterus is seen, and the physician does a laparoscopically assisted vaginal hysterectomy 20 days later of a 236-gram uterus, and it says to report only the hysterectomy. So we're going to look up a hysterectomy, and it was done vaginally, and it was done laparoscopically. 1072. You're going to look up hysterectomy, vaginal, and then laparoscopy. Then we're going to look at page 436, and they are divided up when you take a look at that by the grams. So 58550 is laparoscopy, surgical, vaginal hysterectomy, and the uterus is 250 grams or less. So that's the code. .12. This one was a little bit tricky. Attending physician who has provided Sally Fisher's OB care performs this cesarean delivery due to a breech presentation and ligation of the fallopian tubes, which is a sterilization at the request of the patient, and routinely followed up with Sally in the postpartum period. I really don't care how much the newborn was weighed. Bottom line is they did OB care. They did the antepartum, they did the delivery, they did the postpartum. So we're going to pick up OB care, but they did a cesarean. So when you look up routine OB care, I mean, and you look it up that way in the index, routine OB care. If you go to page 442, $59510 is routine OB care, which includes the antepartum, the cesarean delivery, and the postpartum. That's exactly what was done. And then I'm going to go ahead and pick up an add-on code because they did the sterilization at the time that they did the C-section. And that's on page 438. Code's 58611. And again, that's a add-on code. And it's a ligation of fallopian tubes when done at the time of a cesarean delivery. $14. Biopsy of 3 lesions, and I can't remember on this one why people had, I can't remember why. Biopsy of 3 lesions of the vulva. So you're going to pick up biopsy vulva, and we're going to pick up the 3. The 56605 on page 429 is for 1 lesion, and then each additional lesion you pick up with 56606. So there were a total of 3. So I'm going to pick up 56605 one time, and then I'm going to pick up 56606 2 more times. I coded as 56606 times 2, but you know, some of you did give me 56606 and listed it twice. It's easier if you do it times 2. Question 15, fitting and supply of a diaphragm with instructions for use. Most of you got the diaphragm fitting. And the way you look that up is contraception and then diaphragm. That's on page 1012 in the index. Most of you got the 57170. What you didn't get was the supplies. That's another one of those that because they fit it, I mean, they have to get the diaphragm and put it in, and you are allowed for diaphragms to go ahead and pick up the supply code. Again, if you're doing hick picks and you want to get really picky on which kind, you can do that, but you know, you can use the 99070, which is like the dump all supply code, medical supply code. Question 16. And again, these next 3, I only had 1 person that missed them, so I'm not quite sure. Again, I can't remember because I did see some numbers that I thought were transposed. To me, if it was something that I thought you just made a keying mistake, a lot of times I counted that correct, and maybe I shouldn't have. But I won't do that for a midterm or a final, but you know, for your homework I do. But anyway, on this one, you would go ahead and look up the biopsy of the vagina. And that does include closure. Extensive includes the closure. There's only one code, 57105 on page 430. On question number 18, simple incision and drainage of an abscess of the vulva. If you go to vulva on page 1189 and then look under incision and drainage and then pick up abscess, you're going to get 56405 on page 429. And number 19 is just a straight up, you just look at that term. I mean, if you look that up in the index on page 1011, you're going to, there's only one code listed, 57020, and that's on page 430. Do you all have any questions on homework? Now, this time, this go around, the GU is not going to be included as a whole. I mean, that doesn't mean that I'm not going to, I might ask you something, you know, coding is coding. But I'm not going to ask you GU type of scenarios specifically for the midterm. That'll be on the final. And just so you know, final is comprehensive, but I lean more toward the second half, starting with GU. I kind of weighted a little bit more with those codes since I've already, you know, the midterm is the first half, but the final is comprehensive, just so you know. Any questions? Okay, let's go through the midterm review. I'll go ahead and, you know, call them out by the question numbers and then kind of refer to, you know, the workbook numbers. Okay, the first one is going to be a simple repair done on the cheek, and they used a surgical tray. In that particular case, they're telling me they used a tray, so I'm going to pick up that supply code 99070. And on the repair, you would go to repair and skin. I think it's easier just to go directly to the repair codes in the CPT book, because when you look up repair skin, you do get a code that is not the code you end up using, because they're done by anatomic area. So let's go and take a look at page 104. Repair start, and I'm going to, again, remind you on page 102 and 103, you've got narratives about repairs. Remember, repairs are divided up into 3 separate categories: simple, intermediate, and complex. If they happen to be in the same category, meaning simple, intermediate, or complex, and the same anatomic area as is designated by the codes or the root code, you combine those codes together and sum them up. But if they are different anatomic areas, you do not. You also cannot sum up like a simple and an intermediate. They have to be same category, same anatomic area. So basically, make sure that you understand the notes. The notes are there. And this one, we're looking at a simple repair of the cheek, and that it is 16.2 centimeters. So if we're going to look up simple repair of the cheek, that's going to fall under the category of 12011, because that is, the anatomic areas are face, ears, eyelids, nose, lips, mucous membranes. We're going to go down for the 16.2 centimeters, which is 12016. And that's the code. And then I'm also going to pick up the surgical tray, which is 99070. For number 2, we've got a debridement of sub-Q and muscle. Again, I'm going to, on the debridement codes, you want to look at the depth. Is it, you know, down to the bone, the muscle, just the sub-Q area, and also the square centimeters. Let's look at 11043 on page 92. 11043 is debridement of muscle, and it's the first 20 square centimeters. Again, remember that your codes are going to start with 11042, which is the subcu tissue. The 4-3 goes down to the muscle, and then the 4-4 goes down to the bone. If you have additional square centimeters, then you're going to use the indented code. In addition to for question number 3. And again, for a lot of these skin lesions, like if it's each additional or a continuation, I don't use a 51 modifier. That to me, or these are the same. You treat them the same way that you treat an add-on code. Question number 3 is a debridement of 4 fingernails. Let's look at page 101, because this is divided up by the number of nails. And we're going to look up code 11720. 11720 is for debridement of nails 1 to 5. And then if I debride 6 or more, I'm going to use 11721. But in this case, they did 4 nails, so we're going to pick up 11720. Question number 4 is the destruction of a malignant lesion. Remember that those malignant lesion codes, the malignant and the benign, are going to be the 114 codes for benign, the 116 codes for malignant. You definitely need to know if a lesion is benign or malignant, if they excise it. Again, looking at the notes for benign on page 97, and then also looking at how they excise it. Again, the margins. The margins are the same, whether it's benign or whether it's malignant. But if there's 4 lesions, you're going to have 4 codes. This is not summing them up like you do with repairs. Now for destruction codes, those aren't excisions, those are destructions, because again, destructions are where they, you know, I call them poof, you know, where they laser them, or, you know, they destroy them. So there's no tissue that's left. But they are divided up by malignant or benign or pre-malignant and then malignant. So the destruction codes start on page 117. In this case, we're picking up a malignant code, and then we're picking it up by anatomic area and size. So we're picking up an eyelid, and it's 4 centimeters, and that would be 17284. You all got 5. Let's look at 6. This is one of them that I think you all have trouble with, that 58 modifier and understanding casting. So we'll go through that again. This is a patient that comes in 2 weeks after they had a long leg cast put on, and they need to have a new one put on. So they're taking one off and they're putting another one on. This is going to follow in the global period. In the global period, if you take a cast or you do anything related to the repair, you add a 58 modifier. Think of it in the same way as when you get stitches. You can't leave them in there unless they happen to be dissolvable, but you know, you go back and you have to have the stitches taken out. That's included. You know, you don't charge the person to take your stitches out. That's included when you put the stitches in. And it's kind of the same way with the cast. Anything related to that cast, if you know, you have to come in, you're going to go ahead, and if you put the cast on, you're going to have to take the cast off. So that's included in the global fee. But if you have to take one off and put another one on, that is something different. So in that case, I can go ahead and bill for the second application with the 58 modifier. And you can also pick up supplies with that too. If you need to look at that rule again, in your textbook on page 422, it does talk about the 58 modifier and the global. I believe it's at the top of the page. It's at the top where they talk about the application service is bundled into all fracture repair codes, as is the removal. If a subsequent cast is applied within the follow-up period for either the surgical procedure or the fracture repair, you can bill the application with a modifier 58. You can also bill for the materials. I also want to draw your attention to the bottom where it talks about application of casts. I think in your mind, you're making it more confusing than it needs to be. Now, if I have one doctor that puts the cast on and I have another doctor that takes it off, the first doctor can bill for the application. The second one, this first time I've ever seen him, and I'm taking that cast off, you can bill for the removal. Now, if the doctor who originally put it on takes it off, no, he can't bill for it. I mean, does that make logical sense to you? So kind of think it through, think the scenario through on what are the circumstances here on, do I bill for it or do I not bill for it? It's kind of the same thing with a global surgery. If I did surgery on the patient and I keep seeing the patient afterwards in the global period, I don't bill anything for that. But if I see the patient for something totally unrelated, yeah, I can bill for that. Question number, is that clear to you all? Because I want to make sure, because I've had a couple of questions about the 58 modifier and when to use it. So I want to make sure that the way I explained it, that it makes sense to you. Okay. Question number 7. We have a closed treatment of multiple pelvic fractures without displacement of the pelvic ring, without manipulation. Now, remember on fractures, you're going to look up the main term fracture, then you're going to look up the anatomic, same thing with the dislocations. Then you're going to look up the anatomic area. Then we're going to look to see, is the treatment closed or is it open? Is it with manipulation or without manipulation? And remember, if you attempt manipulation and it's not successful, it's still considered manipulation because you tried. So in this case, when you look up the main term fracture and then closed on a pelvic area, you're going to get on page 184, 27197 is the code. I think some of you just didn't read the description with the pelvic ring. 8, same thing, we've got a dislocation. The anatomic area is hip, and then we're going to look to see if it's open or closed treatment. It's open. So we're going to pick up open, and you're going to get 27253 on page 185. Again, to look it up, dislocation, hip, and open, that's on page 1023 of the index. Number 9. And this one, I'm not quite sure why you had so many problems. So I'm going to look this one up with you. This is a closed treatment of a tarsal bone dislocation. So we're going to look up dislocation, page 1024, and the anatomic area is tarsal. So 1024, dislocation, and then tarsal. And then we're going to go ahead and look up the closed treatment, which we've got 28540 or 45. So let's go to page 201. Let's look up 28540. And it says closed treatment of tarsal bone dislocation. And these two are divided up with and without anesthesia, and they tell you it's without. So 28540. Number 10, removal of deep screws from a repaired fracture. And they tell you that screws are a fixation device. So basically, I'm looking for a removal of a fixation device. And if you look under removal fixation device on page 1146, you're going to get code 20680. And that code's on page 139. Subsequent removal of a short arm cast by the physician who applied the cast. Now, this is one that I can't bill for it. It's in the global period. So I needed to either see something where you would say that it's a post-op visit, or it's in the global period, or better yet, that you pick up the code for the routine follow-up care, which is 99024. I would have taken any of those. I mean, my preference is that you pick up the code, which is 99024. Because again, the person who applied it took it off. You can't bill for that. On number 12, arthrocentesis of ganglion cyst of toe joint. If you end up having to look up the main term aspiration on page 988, and then look up cyst and ganglion, which gives you code 20612 on page 139. Because a lot of you got this one wrong. I don't know why you've had problems with this one, but 20612 is an aspiration or injection of ganglion cyst, any location. And for any of you that got that wrong, you're going to have to tell me why why you had problems with that, or now that you saw the code that you understand, because that's the only code you can get. So I'm not sure what you looked up.
I have a question.
Yep.
On 11, I put, it's noted that removal of the cast is included in the procedure. Should I have included when it's done by the same physician? Because I got that wrong.
No, what I was really looking for was the code. I mean, you understood the concept that it was in the global, and that's okay. What I was really looking for, because I gave you a couple of different casting codes to see if you understood, I can't bill for this, or I can, and that I add the 58 modifier. I want you to understand the concept that you got paid for that when you originally put the application. So if you understand that, we're good.
Okay.
Okay.
On the ganglion cyst.
Yep.
I did end up getting it right, but I know originally I was really looking at 20600. You were asking,
Yes.
yeah, just because it had said toe joint, and so I sort of fixated on that. I mean, I did
But it
find,
doesn't say ganglion cyst, does it?
nope, and that's, yeah, I mean, I got it. I got there
Yes.
eventually, but but that's definitely where my mind went first.
Okay. And that might be what other people did. Again, a lot of these words matter and other words don't matter. Sometimes you all get fixated on stuff where it's just like, who cares? Kind of like when I said, I don't care how much that baby weighed. That had nothing to do with my ability to pick up a code. And other times it does make a difference. So, once you get more familiar with the codes, you see that one word makes a difference on, do I pick up this one or do I pick up that one? Which you all are still learning, so a lot of times you're not going to appreciate the detail, or from a terminology or an anatomical standpoint, you may not understand it that well. And it isn't until after I show it to you where it's like, well, it's this one and not that one, that you recognize that, gee, that word made a difference.
That's absolutely what happened on that one for me.
Yep. Number 13, which is a 5-year-old who swallows a nickel. Patient needs an indirect laryngoscopy to remove the foreign body. Now, this is one of those that when you look up the laryngoscopy codes, it's either direct or indirect. And this one is, you're going to look up laryngoscopy indirect and to remove a foreign body, 31511 on page 219. And I can't tell you how many times working in the ER, kids swallow the darndest things and they stick things in their nose and their ears that are unbelievable. It's just amazing to me that the kids can even get stuff up their nose and down their throat. I had a student last semester who, she had a 2-year-old and he had a cough. So she kept on thinking that he had a cold or whatever. And after a week, she took him to the emergency room and he had swallowed a button and it was stuck down in his throat. And they ended up having to put him under, to go ahead and take it out. But she said, I feel really bad, because I just thought he had this bad cold, because she never saw him swallow it or anything. Okay, on 31511, that is a removal of a foreign body. And if you notice, it is indirect compared to direct, which starts with 31515. So that's the main word that makes a difference, is direct versus indirect. 16. Double lung transplant with cardiopulmonary bypass. Now, this code is divided up with and without bypass, and single versus double. So I don't know which one of you all, which word you didn't like. Page 231. (32854) is lung transplant double with the bypass. The 5-3 would be double without it. And then the single, the 32852. So again, it makes a difference. Is it single? Is it double? Is it with or without? So I know you all made a mistake on one of those things. 18. Coronal reconstruction for lung cancer. If you look up the main term, reconstruction, trachea and carina, you get 31766 on page 224. And that's the only code that's in that when you look it up. $19 is repair of a coronary AV fistula without cardiopulmonary bypass. In the index, I looked it up as repair coronary artery or coronary artery and then repair. And then I picked up an anomaly and I got 33501, page 257. $33501 is repair of coronary AV fistula. And then without the bypass is 01, with the bypass is 00. $20. This is one of those, I think you just using synthetic vein versus vein. Bypass graft, common carotid ipsilateral internal carotid artery, and they used a synthetic vein. You should have used 35601. And I think some of you, a lot of you used 35501. 35501 is with a vein, and 35601 on page 288. So you can look at the description. Bypass graft with other than vein. And it's because they did the synthetic vein. Whereas the 35501, which is on page 286, it's with vein. Vein, when you do the vein, it's going to be more cadaver or that they harvested it from you. Whereas a synthetic vein is more it's made of something else. $21. Coronary artery bypass, single artery. And this was done cardiac. So if you look up bypass artery cardiac, you get 33533 on page 259. And I do need to make sure again that you understand all the anatomy, and I've given you, handouts that listed all the arteries, because I know the way that I went ahead and wrote them. I put specific, I said that it was an internal mammary to a circumflex, or that it was a lima, or left internal mammary. I did them that way because that's the way they're normally written in a note. So I need to make sure that you understand your arteries and your veins so that you can distinguish, oh, this is a vein to a vein, or a vein to an artery, or an artery to an artery. Because again, you do either vein or artery. If it's a combination artery vein, you do the artery and the add-on vein code. My passes aren't hard to code. It's just understanding all of the terminology that goes with it. 22, repair of injury to intra-abdominal blood vessel, inferior vena cava, hepatic vein with a vein graft. I looked up repair blood vessel abdomen with vein graft on page 1148. So again, I went repair, then blood vessel, that it was in the abdomen and that it was done with a vein graft. And I got paid, I got 35251 on page 285. $35251, which is repair of a blood vessel with vein graft intra-abdominal. $324, 25. Repair of laceration of diaphragm, and they did it as an abdominal approach. Look under the main term repair, then diaphragm, then laceration. You get code 39501 on page 330. '27, enterotomy of the small intestine for removal of a foreign body. I looked that up in the index under enterotomy and then foreign body removal on page 1034. And I got 44020 on 358. Which is enterotomy, small intestine, for exploration, biopsy, or foreign body removal. And then 28 is a partial colectomy with a colostomy. Now, again, I'm going to look up the main term colectomy and partial on page 1009. And then that it's with a colostomy. And I get 44141 on page 359, which is colectomy partial with skin level colostomy. '29. This is one where a lot of you gave me a non-laparoscopic code. Surgical laparoscopic placement of a gastric band. What they did was basically the gastric restrictive, where they band you. I looked under laparoscopic, and then I think I went to stomach. I'm trying to read how I got to it. And then I looked up gastric restrictive procedures, page 1089. And I got 43770 on page 356. And those can be done laparoscopic or open. So you need to make sure that you pick up the laparoscopic approach. And I think the one, a lot of you got it wrong because you did it open. So 43770 is laparoscopic surgical gastric restrictive procedure. And then they have gastric bands. And the last one. This is one that's a little note saying that they did a screening colonoscopy. Basically, they did a colonoscopy and they found polyps and they did a biopsy of them. So what I'm going to pick up is a colonoscopy with a biopsy, page 1010. And I looked it up, colonoscopy biopsy, page 371, 45380. Colonoscopy with biopsy. Any questions on basic did you have problems? Did you not have problems? I tried to give you some, review of different types of things to refresh your memory, to ask questions. Again, a lot of it, that's a lot of material. There's 50 questions on the midterm. It's a matter of, am I going to pick the things that you're good at or not good at, that are confusing to you, that are not confusing to you. Some of you are going to think it was the most miserable thing in the world, and others are going to be, oh, that wasn't that bad. It's just a matter of what your strengths and your weaknesses are. So I want to make sure, because there's a lot of material, that I can pick from. And again, I can concentrate on one area more than the other. I tried not to do that. I tried to be pretty even-handed, but there are 16 multiple choice. And the rest of them are all pretense. There's some of it that just settle yourself down. A lot of the questions that I ask, if you know where to go in your book to find the answer, you're not going to have a problem. I'm going to ask a lot of questions that relate to terminology, that is going to relate to the guidelines or to the notes, that are before some of those codes. As long as you know where to go and to look for those things, you're not going to have any difficulty. Some of the other things are just straight up codes. They're pretty much going to be the things that I picked, like excision codes, destruction codes, debridement codes, definitely bypass. I can't remember if I asked you anything on, PTCAs or EKGs or that kind of thing. I know I asked some stuff where you do have to, know the different sections to go to for cardiac. Also, modifiers. I'm looking that you know how to do basic modifiers. That doesn't mean you slap a modifier on just for safekeeping. I need to make sure that you understand the rhyme or reason of why you go ahead and put it on there. So again, are there any specific questions that you have? Were there any problems that you encountered when you were, doing the review, or some other things that came to your mind that you need some help with or guidance on? You're all ready to roll. You can take it as soon as we finish, right? Okay. You have 2 hours to do it. I do have it set so that when you get the 2-hour flag, I have allowed 10 minutes grace period, so that if, let's say, you had some that you wanted to go back and double check, or that you need to finish up or whatever, that I've given you that 10 minutes grace period, so you're not as rushed in a 1 minute time frame. But don't take advantage of that it's like, oh, okay, I got another 10 minutes to finish things up. Make sure you save as you go. Again, what I normally do whenever I do coding, I always have a piece of scrap paper, so that I can write things down to kind of keep myself on track, especially if I have multiple codes. I don't want to keep all of that stuff in my mind, or sometimes it's between this or that. And a lot of times I write things down. That's perfectly fine to do that. But you might want to keep track of ones that you want to go back and take a look at. So that if you have time at the end, that you have that time, or, you use when the time's called, that you go back and double check on certain things. But I'm just telling you, you have the 2 hours and there is a 10-minute grace period. Now, I've had some students tell me in grace periods, they've not been able to do anything. That's not the way it's set up. You truly do have 10 minutes that you can submit. So, but I wouldn't, wait until that period of time. I just think it's safer to go ahead and save as you go. Now, if you do have problems, let me know right away. Another thing that I've had students do, and I can see, because I can go in and see when you started a test, when you ended it. I can see exactly when you save things and other types of things. I can see when things freeze up on people. And, unfortunately, computers update, power goes out, but thank God, I think we're supposed to have rain on Friday. But other than that, I don't think we've got any storms or tornadoes coming through. But things happen. So make sure that if that happens to you, that, you at least write some things down where it's, where I can go ahead and I can at least manually look at that. Just tell me, I was supposed to be number 2, or this is what the code should have been, or whatever it happened to be. But, you're going to have to let me know right away if you have that issue. Are you all ready? Are you good? Kind of, sort of. Justin, you don't look the least bit happy. Are you sleepy? Okay.
I just default to a neutral expression, so.
Oh, okay. Got it. I'm going to go ahead and you've got your midterm that's due. Again, you have till Saturday at 11 o'clock. Make sure that you give yourself enough time. Don't start that test after 9 o'clock on Saturday, because it will cut you off. It isn't that you get to start at 11 o'clock and you have 2 hours. You have to be done by 11 o'clock on Saturday. I've also given you so that you have time, because we are doing the next 2 chapters, which is thyroid, the endocrine, the spinal, ear, and eye, which those are not difficult chapters. Those are chapters that it will be easy for you to read. There's a couple things I will bring to your attention that you need to kind of focus in on. But those are pretty straightforward. I will tell you that just from a coding standpoint, I don't focus that much on eye, other than, you do basically have to know some terminology, but eye surgery is very specialized to ophthalmology. So I want you to be familiar with it, but I don't dwell on it like I do general surgeries or some of the other surgeries that are definitely more mainstream if you're going to get an initial job. So that one, I'll just tell you, I'll kind of tell you what the terminology is that I want you to know. But again, it's pretty straightforward on reading it. and there is homework that is due as usual on Monday. So next week when we get together, I will go through the midterm and I will go through the homework. I think I have the midterm set up so that you will only be able to see your score. You won't be able to see what you got wrong till everybody is done. So you'll initially, after I grade it, when I post the grade, you will see what your score is, and you won't be able to see what you got incorrect until starting on Sunday. Because I'm pretty quick at grading. So after everybody submits and after I post the grades, you will be able to go in and look specifically at what you got incorrect. So I just want you to be aware of that, because I do that a little bit different on the midterm. Okay. Endocrine, which is chapter 22. That's the one that I was telling you that at the end of the female GU system, that it's kind of weird because they stick the thyroid and parathyroid in there. That's like endocrine, I guess, because those are the only endocrine and adrenal glands. So I guess they just kind of flip it in there before they go on to the nervous section. But if you look at the table of contents, it's on page 428. It does show you, there's just a few surgeries that do deal with thyroid, parathyroid, just 2 pages. Page 444 and 445 are going to be the codes that you're going to be taking a look at for thyroid and parathyroid. You just need to make sure when you're doing the thyroid, is it total? Is it subtotal? Do they go ahead and do the contralateral where they take the isthmus out at the same time? In other words, just look at the detail of the thyroid, parathyroid codes to see how they differ. And then also there is some laparoscopic. The laparoscopic is for adrenal, which is on page 446. So, that's just straight up, understanding what's the thyroid, what's the parathyroid, and kind of understand, the parathyroid, those little glands are in the thyroid. And then you got the isthmus that divides, the two sides, the lobes up, or the hemispheres, what I call them. Those are pretty straightforward codes. So nervous system is going to deal with basically the peripheral as well as central nervous system, and it's the nerves. The brain is also included. If in your textbook you look at page 588 and 5 through 590, anatomically it's going to go through the different pairs of nerves, like cranial, spinal, what they control, if you don't remember that. They also, talk about the brain and the spinal cord. A lot of it is terms and anatomy, because you need to know that when you're looking up the different codes for the nervous system. The nervous system table of contents starts on 447 and goes through 449. There are some diagrams that will help you. Also, you'll be able to see the different types of surgeries that are included in here. When you're doing anything, and the biggest thing is probably going to be brain surgery, where they'll always say, I did a craniotomy. Well, a craniotomy is an approach. So a craniotomy just means that they cracked into your head. So you did a craniotomy for what? So the two things that you always want to look at is the approach and the purpose. What did you do? Did you clip an aneurysm? Did you get rid of a bleed? Did you take out a part of a lobe? Did you take out a neoplasm? I mean, what did you do? And again, what was your approach? Where did you cut into? So on the craniotomies, you can go ahead and pick up an approach and the procedure. A lot of times, and they'll explain this to you on page 452 in your CPT book. It's in your textbook too, but I want to show you that it's also in your CPT book. They do explain approach, definitive procedures, and they explain what that is. And this can be done by one provider, or it can be done by 3 different providers, because you can have one person that does the opening, another one he goes in and does the procedure, and you can have somebody who does a repair, or you could have one person that does all of it. So you really do need to understand those 3 different things. And if you look in the CPT book, they have the approaches set up by anatomic area, like the anterior cranial fossa, middle, posterior, then the base. Again, they have it divided up to kind of make it a little bit easier on what that approach and procedure is. Some of the codes are going to go ahead and they're going to be divided when you're looking at the code, like aneurysm repairs on page 456. They're going to already explain right there what they're doing, and they're going to have the approach listed in there, so that you're not doing a separate approach. The approach and the procedure are combined together. Cerebrospinal fluid shunts are included in here too. The other thing is the spine, not to be confused with the procedures that are done in musculoskeletal. Musculoskeletal is going to be more, the procedures you see are more arthrodesis, where in here it's going to be more where they are dealing more with the nerves as opposed to the bone. So there are definitions and notes in your CPT book, starting with 461. 462 in your CPT book has the definitions. Again, these are also listed in your textbook, but they're right here so that you can go ahead and, read those to understand that. Posterior, anterior, they do describe that in your textbook. You do, because whenever you deal with the spine, it does make a difference on if you do a posterior, which is from the back, or if they do it anterior, which is from the front, because a lot on the cervical, they can either do it where they have you lying on your back or lying on your face. So you do need to look at approaches. Again, make sure you don't confuse the two. And most of the time when you look the codes up, I mean, it's going to take you to the right area, whether it be the nerve, the 6 series codes, or the 2 series codes, which are musculoskeletal. But I want you to understand the difference between anatomically what they are, because that's usually what I always get. How do I know which one to look up? There's a few things in your textbook that I do want to bring to your attention at the end of the chapter, starting on page 595 in your textbook. The 2 coding shots that are on 595 that are dealing with injection codes. The code 62280 through 82 is the first one. And you can correlate those codes in your CPT book on page 463. And then the second coding shot is going to talk about when you use fluoroscopic guidance. And those are on page 464. And again, that code range they have listed is 62320 through 26. So that again, you can correlate those and you'll see, that the fluoroscopic guidance is included in there. At the bottom of 595 going on to 596, they do list out the different nerves. There are going to be times that you do injections into specific nerves, or you're going to be doing blocks. Blocks being that, it is going to control a block of nerves, and those are going to be included on page 596. So you've got your basic nerves and what they control along with the blocks. It might be helpful for you if you correlate some of this with the table that's in your CPT book on page 475. They have codes listed and they do talk about, whether you use imaging, if you don't use imaging, and they do also kind of talk about the different nerves and the blocks, which you might find helpful. And then chapter 23 is the one that deals with eye and ear. You can take a look. The eye and the ear are separate table of contents. The table of contents for the eye is going to be on page 485 and 486. And again, I'm going to point out some terminology that I want you to be familiar with. But I'm not going to put a huge emphasis on coding eye. In your textbook on page 601, the coding shot where they do talk about, bilateral or right or left, it does make a difference on eyeballs, just like sinuses. I need to know, is it right or left? Those are definitely, the right and left definitely are going to go ahead and be used. All of the terms that are bolded, I kind of want you to take a look at those and know what they are, so that at least if you have to code something that, you're familiar with the terminology and the anatomy. They've got, good diagrams in the textbook as well as in the CPT book. So, that's going to help quite a bit for you to be able to pick things up. On page 605 in your textbook, they talk about, these are going to be cataract removals where they put a lens in. You can do them extracapsular and intracapsular, and you definitely need to know those acronyms, the ECCE and the ICCE. And those codes are on page 492 in your CPT book. But I definitely, those acronyms you need to be aware of. EC is going to be extracapsular, IC is intracapsular, and you need to understand that. Also, for the eyes, this is where you're going to be using your E codes, if they're the eyelids, the right, left, upper, lower, the E1 through the E4. So make sure if they're doing something on the eyelid that you use the appropriate modifier. The table of contents for ear starts on page 503. Now, the biggest thing that you're probably going to see with ear is going to be where they put tubes in kids' ears. The tympanoplasties and the myringotomies. Myringotomies is where they just cut into the tympanic membrane. But you're going to see a lot of that where they pop those tubes in for kids. So there, again, pretty straightforward. It's just a couple of pages. I will focus you on page 611 in your textbook for the operating microscope, and I'm going to correlate that with the code that's on page 508. The code is 69990. And this is any time that they are going to do microsurgery. You know, there's a lot of times that doctors do use an operating microscope, or they call it something else. Micro dissection is something that's where they're going to use an operating microscope. And it's an add-on code. If it is not included in the description of a code, you can pick this code up. There are times where the operating microscope is included in a code, and so therefore you cannot pick this code up because that would be double coding it. Magnifying loops are not included in the operating microscope. I know that one of my doctors, he did a lot of vascular stuff, and he always, you know, had his loops with him, but that just magnifies the area. That's not a it's not considered in this particular code. If I see that they use loops, I'm not going to pick that up. Let me give you, because I know a laryngoscopy is one of the codes. So you can see what I'm talking about with and without the microscope. Sorry, I should have looked this one up and had it ready to roll. Page 219 in your CPT book. Let's look at code 31571. This is a laryngoscopy, and it says with operating microscope. This is one that does include the microscope in the code. So it would be inappropriate for you to pick up the 69990. The only time, again, that you're going to pick up this code is if they use the scope or they use microdissection, and you need to pick that add-on code up. And that's it for those chapters. Like I said, these are pretty straightforward chapters. There is terminology that you may or may not be familiar with, and that will be due Monday night like it always is. So you just have the midterm and you've got the homework. Next week, we are going to start the next chapter, which is radiology by itself. So do you all have any questions? Again, the midterm will open at 7 o'clock in the morning. You do need to take it through the lockdown, just like you do your quizzes. Make sure you allow yourself at least 2 hours to take it. Is there anything else that you can think of or that I can help you with before you take it?
I wouldn't mind going back over the numbering of the fingers.
Okay. You start with, and you can look at this on your front cover of your CPT book, where it's got your left hand, thumb, and then it's also the foot, because the fingers and the foot are identical. The fingers are F codes and the toes are T codes. And if you take a look at those, the first code is an FA code, which is the left-hand thumb. So we're going to use the left-hand thumb. Then my index finger on my left is going to be F1. Okay, so I start out with A. I start out on my left hand. My thumb is A. My index finger is 1, then 2, 3, and 4. So my pinky is going to be F4. Then I'm going to move over to my right hand thumb. So we're going to continue on from 4. So my right thumb is going to be F5 and 6, 7, 8, and 9.
Isn't there also a list of it in the back of Appendix A?
There is, but if you want to do the quick and dirty, you know, a lot of times the front cover is easy to look at, but you can also look at Appendix A. That is also going to be on page 883. The eyelids are there, the toes are there, the fingers are there, and then those 59 X codes are there. But again, all of those are also on the front cover. So it's whatever, you know, anybody is comfortable utilizing. For me, I kind of just count in my head and look at my fingers, you know.
I just think I need to go back over on my own quiz number 2 because it's the only quiz that I did very poorly on, and I need to look back over it and really understand where I was so confused. And I thought it was on the fingers, but everything you said made sense to me. So I'll just have to look back over it on my own.
Yeah, and when you go back through them, and if there's something you don't understand, I mean, you can absolutely shoot me an email. I mean, you know.
Yeah, I'll probably do that if I
Exactly.
don't
I mean,
understand.
Any of you, you know, and those of you that have me another, because I know that several of you have reached out to me, whether it be to pharmacology or patho or whatever. I mean, you know, whatever subject you have a question on, it's not a problem, you know, just email me. I'm pretty quick to respond to an email. So, you know, the only time I can't is if I'm teaching, you know, another class or in meetings or whatever. But I mean, it's unusual during the daytime to make you wait more than 4 hours for a response. But it's happened before. I know Wednesdays is a pretty bad day for me because I've got, after class, I have meetings back to back usually, you know, until about 5 o'clock. So sometimes it's more difficult on Wednesdays for me to answer things pretty quickly, but I do. So anything else? Again, I want to make sure that you totally are prepared and you're comfortable before you have to take that.
Can you explain what body parts to use LT and RT on?
I don't necessarily, I use it more for organs, you know, where you've got mirror images of things. Just because it says right leg, left leg, I mean, I'm not going to go ahead and, you know, if it's an arm or a leg, I'm not going to go ahead and get crazy. But just because I see something that's an arm or a leg, I don't generally pick up RT and LT. I do if I see a history that they did an amputation on the right and now they're coming back and having it on the left, then I'll use, you know, because I want to show this isn't a duplicate, you know, this is another separate surgery, so that it's more for insurance purposes that I do that. Now, if I'm doing surgery at the same time using right and left, if it is that I'm, you know, breast, hernia repairs, those type of things. I mean, most of the time I'm going to use a 50, you know, because they're usually done at the same time. Sinuses are definitely something that I would use right and left, you know, to be able to show the difference on what side. Eyes are something that I would use right and left if it's not the eyelids. But if I'm doing the right eye versus the left eye, a lot of times I'll do that for ears too, you know, like if they're, depending on what it is. Yes, but if it's tubes, I definitely use right and left for that to be able to show. Is that helpful? Or is there one in particular that you're confused over?
Yeah, that's helpful.
Okay.
Is there a key to when to use supply codes? Like something that stands out to know when to use the supply codes?
If it says surgical tray, you know, I definitely am going to do that. I definitely would use it with casting. You know, any orthopedic type of thing, when they give you crutches, when they do splints, when they do that type of thing, I will go ahead and pick that up. Other times it's just a matter of some of it, you just have to work for a while to recognize that, oh yeah, you know, I can bill for this particular thing.
Okay.
Ones I've given you have pretty much been like surgical trays for sutures or orthopedic type of things.
Okay.
And there are usually, you know, HCPCS codes that start with the letter, you know, like A codes or B codes or C codes or whatever, that generally, you know, when you're in the real world, you'll be more specific and use HCPCS codes.
Okay.
Anything else? Okay, let's see how well I taught you. Don't let me down, because it'll be really terrible if you don't do well on this, because that means that I didn't do a good job of what I was supposed to do. So this isn't about you. This is about me. Okay. Just kidding. Just kidding. But hopefully it, you know, I taught you well enough that you won't have difficulty with it. Well, then I will see everyone next Wednesday. And Amy, you stay on.
Yes, ma'am. I'm
Okay.
staying.
You're staying. Okay. All right. I'll see the rest of you next week. Good luck on the test. And if you need anything, let me know.
Thank you. Goodbye.
Bye.
Bye, everybody.
Bye.